Hey. I just said to Johnny and him, I said, oh, we're gonna have to start like a couples engagement. Let's use science department couples engagement party or something. I don't know. Oh, it's okay. I don't get warm today. I don't know why I stay out there.
Jack told in my office.
This one doesn't really go, but that's like, you wanna wear. I'm always saying, like, I don't use to wear black.
So there's purple in there.
There you go. Anyway, yeah. Oh, nice slide.
This is it. This is the last one.
And this is right?
Oh, yeah, that's what you're doing.
But they're quick, you know.
Yeah.
You have 10 minutes each. Yeah.
Offshore research. Look, I like your socks. Those are so cute. Yeah. I was down to Tim got me, but I need to go to one of the signing, but he said he's gonna get somebody. So. Hi, are you doing the signing?
No, if I can.
I forgot somebody, so I forgot to ask somebody.
Right now?
What's that?
Did he tell you to do that right now? I'm supposed to do it.
Oh, I mean,
Did he decide right now?
I've been doing it
Okay.
all morning, so you don't have to worry about it, Kaya. I've got it.
Yeah.
Thank you, though.
Yeah, that nose was just great.
Hello, welcome back to our Capstone presentation. Luke will be giving our first presentation. He's majoring in biology with a concentration in med science. He's from Tulsa, Oklahoma, and has been here for 4 years. He's been part of the cross-country team, track and field, and a TA for anatomy. Shout out to that. Organic chemistry and biochemistry. So we do a lot of TA. After graduation, he hopes to attend medical school at Oklahoma State. Take it away with some cardiology for us.
Hello everyone, my presentation will be looking at endothelial and mesenchymal stem cell-derived exosome therapy for restenosis prevention. So first of all, what is coronary artery disease? Coronary artery disease is the most common form of cardiovascular disease in the United States. It accounts for over half of all cardiovascular related deaths. It is primarily caused by atherosclerosis, which is the accumulation of smooth muscle cells and necrotic debris underneath the endothelial layer, and this forms plaques, which lead to reduced blood flow. People that are at high risk are people who smoke, don't do enough exercising, have a diet that's high in cholesterol and fats, as well as obesity. Some symptoms are angina, which is a chest pain that is associated with the reduced blood flow to the heart, as well as shortness of breath, dizziness, nausea, and heart palpitations. Atherosclerosis is primarily caused by 4 things. These are oxidative stress, which is the excess production of reactive oxygen species, which leads to an imbalance of oxidation and reduction reactions in the body. It is believed to be the key risk factor for the diagnosis of atherosclerosis. Endothelial dysfunction is the first event that is considered to be pathophysiologically significant. It is characterized by low nitric oxide bioavailability in the blood and can provide insights into how severe the case of coronary artery disease is. Platelet activation is when there is a high ratio of platelets to lymphocytes, and then inflammation is due to circulating monocytes adhering to the activated endothelium, and then they infiltrate the blood vessel and differentiate into lesional macrophages or small plaques. So diagnoses are blood testing looking for elevated levels of C-reactive protein, as well as CT coronary angiography, which is a non-invasive imaging technique of coronary arteries. Coronary angioplasty and stent placement is one current treatment. It is also called percutaneous coronary intervention, or PCI, and this involves with going in with a balloon catheter and stent, delivering the stent to the affected area, expanding the stent and opening the artery, and then removing the catheter. And then also another treatment method is coronary artery bypass surgery, which involves taking blood vessels from another part of the body and creating a bridge for the blood to flow around the blockage. The limitations of PCI are that in-stent restenosis occurs in 25% of patients. In-stent restenosis is defined as the re-narrowing of a blood vessel after PCI, and this is primarily caused by neointimal hyperplasia, which is the migration and proliferation of smooth muscle cells from the tunica media into the tunica intima. Bare metal stents and drug-eluting stents are what are used today. Bare metal stents have a higher incidence of in-stent restenosis. They're not as commonly used as drug-eluting stents. In these drug-eluting stents, these drugs that work to inhibit neointimal hyperplasia, but they have a higher incidence of stent thrombosis. So exosomes are extracellular vesicles that are secreted by stem cells that act as intracellular messengers. They contain substances like DNA, lipids, proteins, as well as other bioactive substances that help the body carry out its pathological and physiological functions. Exosome therapy is considered to be safer than stem cell therapy because stem cell therapy has limitations like infusion toxicity, tumorigenic potential, immunogenicity, as well as ethical issues. The first type of stem cell exosome that I will be examining is endothelial progenitor stem cell exosomes. Their primary function is to inhibit neointimal hyperplasia, and this was seen in a study where they injected these exosomes into a carotid artery of a rat in vivo, and it was able to inhibit neointimal hyperplasia. And they also have the ability to differentiate endothelial progenitor stem cells into endothelial cells, which can lead to enhanced endothelial recovery and function, which is something that drug-eluting stents are not able to do. The second type of stem cell exosomes are bone marrow mesenchymal stem cell-derived exosomes. They're primarily involved in managing inflammation. They're able to modulate immune cells like T cells, B cells, monocytes, natural killer cells, and dendritic cells. They're able to suppress the growth of activated T cells while preserving the levels of regulatory T cells, which will help suppress immune system overactivity. And they're also able to inhibit and induce apoptosis in helper T cells, which increases levels of IL-10, which is a known immunosuppressive. So for my specific aims, my specific aim 1 will examine the effectiveness of a stent coated with only endothelial progenitor stem cell-derived exosomes. My hypothesis for this aim is that there will be decreased neointimal hyperplasia, increased fluid size, as well as increased endothelial recovery. And for my specific aim 2, we will examine the effectiveness of a stent coated with a combination of endothelial progenitor stem cell exosomes, as well as mesenchymal stem cell-derived exosomes. My hypothesis for this is that there will be decreased neointimal hyperplasia, increased fluid size, increased endothelial recovery, as well as reduced inflammation. So there are 5 groups for my study. Each group contains 20 apolipoprotein deficient rats, which are rats that are commonly used in atherosclerotic models. They only differ by the type of stent that is used. Group 1 is my baseline group, which will not contain a stent, and I will get into why that is in just a minute. Groups 2 and 3 are my control groups. Group 2 containing a bare metal stent, group 3 containing a drug-eluting stent, and then groups 4 and 5 are my experimental groups. Group 4 containing the stent with only endothelial progenitor stem cell exosomes, and group 5 containing a combination. So what I will be testing is neointimal hyperplasia, lumen narrowing, endothelial recovery, as as well as inflammatory markers. And like I said earlier, group 1 is my baseline group. This just means that in order to visualize the layers of the blood vessels in rats, we will have to use histological staining. In humans, if you want to do this, you can use intravascular ultrasound, but it is not going to fit into the arteries of the rats. And so group 1 will have to be sacrificed before stent implantation so that we have something to look at before or before atherosclerosis, or before stent implantation, sorry. So my timeline is on day 0, each group will receive an injection of PCKS9, which inhibits LDL receptor function and increases the speed at which atherosclerosis is developed. They will be fed a high-fat, high-cholesterol diet for 8 weeks. And then in the middle of the 8 weeks, on week 4, they will have mechanical injury induced to the endothelial cells by balloon angioplasty, which will further increase the speed at which atherosclerosis is developed. After the 8-week period, they will have atherosclerosis confirmed by use of micro-CT angiography. And then once it is confirmed, group 1 will be sacrificed and their coronary arteries will be harvested and prepped for histological and immunofluorescent staining. And then groups 2 through 5 will have their baseline blood work done and will have their respective stents implanted. After 20 weeks, groups 2 through 5 will have their final blood levels taken. They will have their stents removed, and they will be sacrificed, and their coronary arteries will be harvested and prepped for histological and immunofluorescent staining. So the way that I will be testing neointimal hyperplasia and Luminera is by histological methods. I will be using H&D staining as well as Verhoff staining. Verhoff staining, which you can see on the left, makes it very easy to distinguish the two layers of the blood vessels, because it stains the internal elastic lamina, which separates the 2 layers of plaque. And so in this first picture right here, this is what the arteries look like before atherosclerosis is developed. And then over here is afterwards. You can see that the tunica intima right here is much more developed, and it's starting to overtake the lumen. And for endothelial recovery, I'll be using immunofluorescent techniques. My primary antibodies are anti-CD31, which is a known cell marker in endothelial cells, and its secondary antibody will be conjugated to fluorophore-594, which just means that it will be stained red. And my secondary primary antibody is anti-platelet red growth factor receptor, which is a known cell marker in vascular smooth muscle cells. Its secondary antibody will be conjugated to fluorophore-488, which means that it will stain green. And then the whole thing will be counterstained with that. And so on the far right of this picture, in the middle, you can see that there's a red line, which shows the endothelial cells. This is what it should look like. They're continuous and close together. And then there's some space before you get to the vascular smooth muscle layer. That's green. So for blood testing, I will be testing levels of monocytes, T cells, B cells, as well as C-reactive protein, which is elevated in patients with coronary artery disease. I'll be testing that before and after. My expected outcomes are for group 4 with only the endothelial progenitor stem cell-derived exosome stents, but there will be decreased neointimal hyperplasia, increased lumen size, and increased endothelial recovery. And for my group 5 with the combination therapy, there will be decreased neointimal hyperplasia, decreased inflammation, increased lumen size, and increased endothelial recovery. So my future studies include increasing group size to check for consistency in my experiment, and if it provides good results, to move forward with clinical trials, as well as examining the effectiveness of other stem cell exosomes, or maybe combining my therapy with currently drug-eluting stents. For my acknowledgements, I would like to thank God, my family, and friends, and Dr. Solori for being such a good doctor. I could have done that without you. There are my references.
Yeah, can you elaborate, because this is kind of new to me, as far as the difference between your exosome and your just stem cells? So what exactly is the difference? I know you said this is exosome stem cell derived, right? It's a stem cell derived. So how does that actually work when it comes to using it compared to a stem cell, just a stem cell?
So the exosomes are secreted by the stem cells, and like I said, they contain substances like DNA, lipids, and proteins, and they just help the body carry out their normal functions.
So this is naturally produced by the stem cell itself from the bone marrow, you mean?
Yeah, like you incubate the stem cells and then they produce exosomes.
So how do you collect them? Like if you use it for therapy like that, so how do you get the exosome out of the stem cells?
Just by incubation.
It's secreted.
Yeah.
So it's like naturally it will just
Yeah, it's an
exosome.
exocytosis. It's an exocytosis.
So where's the drug? Or how does that look? Nothing, is just whatever is in the exosome is what is the assumed treatment?
Therapy.
Is that therapy? What's in there? I guess that's my question. Like what is it that would make it therapeutic that's in the exosome?
I'm sure all the exosomes have different things inside of them.
Right.
But for the endothelial cells, what's inside them is able to inhibit the neointimal hyperplasia and help modulate differentiation from the endothelial stem cells into endothelial cells. And then what's inside of the bone marrow mesenchymal exosomes is able to modulate inflammation.
There's been already shown the efficacy of that before.
Yes.
In which, I think that's what she's asking. So in the stem cells, so what was done already? What research was done?
Yeah, because I think that's what's missing, because I kind of did not get that, or maybe I missed it, sorry.
So for the endothelial stem cells, there was a study where they injected the exosomes, not like on a stent or anything, into the carotid artery of a rat, and it was able to inhibit neointimal hyperplasia. And then for the mesenchymal stem cell one, there was a study where they made a stent like this and put it into the aorta, and then induced ischemic injury into the hind limb of rats. And
They never gave like where actually in the exosome, because like you said, it could be any lipid protein, right? That's actually in the content of the exosome, and they never like go into the details of why is it that's becoming a very good inhibitor or whatever it is for inflammation or whatever is causing the hyperplasia, right? That's what you're. They didn't actually go into the details. It's interesting.
Management. What happened?
I think it was the same.
New power. You're just like. I think the Star Wars loop is getting into you.
Notice this fully loaded cheese fries that's parked outside our window, and I was like, wait. During the coronary artery disease.
Yeah, it's very, what happens, it's also very technical, that it's like, missing, like, if you stop paying attention for 1 second, even when I'm just reading stuff, I was like, oh my gosh, it's there, I just have to go back and reread it, because I missed it.
Yeah.
Try to follow all the steps. No, it doesn't make it work. It'll be fine. And I'm one of those people, like, I like to clear out my email.
I still have to look this looking for Monday.
Yeah, she said, I was gonna say, I checked for it, you didn't send it.
I don't know what happened. Yeah. I don't know. But
Can you do Tuesday, like, after sweet?
okay.
Like I have a 1, I have a 1:15 and a 1:30, so maybe we could do 1:45. Okay, yeah, I have a meeting in the morning, I have a meeting in the morning, but we could do like 1:45, that would be good. But email me that, because I will never even
Yeah.
remember that. So,
Was it out?
Just sketching my schedule for next semester.
All right, thank you, Dr. Abraham, for also being an IT technician. I appreciate your skill set. This is Italia Dolphy. She is majoring in biology with a concentration in dentistry. She's from Miami, Florida, and has been at SEU for 4 years. While at SEU, she's been a part of the student recruitment team, and after graduation, she plans to take a gap year and study for her BA.
Good afternoon, everyone. So my presentation is on inclusive orthodontics for patients with Down syndrome. So what is Down syndrome? Down syndrome is a genetic disorder that is caused by an extra copy of chromosome 21, and it can lead to physical cognitive features and an increased risk of health conditions. And the occurrence of Down syndrome is about 1 in 17 live births, and women who are pregnant at the age of 35 are at high risk of having a child that has Down syndrome. So the significance of my presentation is to address the urgent need for a more inclusive model of care for patients with Down syndrome. And due to them having behavioral, sensory, anatomical, systemic barriers, they often experience non-occlusion, which is when they have an open bite or a cross bite. They experience delayed tooth eruptions, and that's when their teeth appears earlier. Macrophagia, or the words large tongue or tongue bursting, and they often go through heightened sensitivity to sounds, touch, and any unfamiliar environments that they're in. So since there's a gap in the orthodontic care for patients with Down syndrome, up to 60 to 80% of individuals with Down syndrome are present with non-occlusions. They face many treatment delays, and sedation is often used as a first response for the treatment. And what I'm proposing is a new inclusive model of orthodontic care that will incorporate sensory-friendly and structured behavioral strategies to improve their cooperation during their treatment, reduce their anxiety, and minimize the need for them having sedation. And so my question is, can implementing sensory-friendly and behavioral modifications in orthodontic settings improve a patient's cooperation and reduce the need for sedation in individuals with Down syndrome? So for my specific game 1, I want to develop a comprehensive framework for a sensory-friendly and inclusive orthodontic office model. So my hypothesis is by implementing sensory-friendly modifications, settings such as noise reduction, giving them visual aids, and desensitization techniques, basically the aligners and like touch tools that will be used on them before the treatment starts on them, to see if that will significantly improve the patient's cooperation and reduce their anxiety. And so what will be included in my methodology is the patient will have Down syndrome, known as S121. They'll be able to seek orthodontic care, and there will be a parent/guardian consent that will be required. And what will not be included is if they have any cognitive or physical challenges that would make the treatment unsafe or not possible to be completed. And so for my experimental group, there will be 30 patients aging from 6 to 18. And the first group, they will have sensory-friendly orthodontic care. And this will go on for 6 months, and they'll have to visit every 2 weeks. And for my control group, there will be 30 participants aging from 6 to 18. And this group will have the standard orthodontic care with no sensory strategies being involved. And this will go on for 6 months with them visiting every 2 weeks. And so for my data, I'll be measuring their anxiety levels by using the MCTAS scale, and I will also be measuring their behavior and cooperation by using the Frankel behavior rating scale. And the tests that I'm using is a t-test or a NOVA test, and those tests will compare the group results, and they will alter changes over time. And so for my expected outcomes is that their anxiety levels will be lowered, there will be a better cooperation during their appointments, and there will be increased comfort and improved overall mental experience for them. For my specific A2, I'm going to investigate the orthodontic treatment needs of individuals with Down syndrome. My hypothesis is by using structured behavior management strategies such as the tell-show-do method, giving them positive reinforcements during the treatment, and having the parent be involved to see if that would reduce the need for sedation and increase the rate of completed orthodontic treatments in individuals with Down syndrome. And so what would be included in my methodology is the patient will be diagnosed with Down syndrome, they'll be medically cleared for orthodontic care, and there will also be a parent or guardian consent. And what would not be included is if they have any medical conditions, if they're nonverbal, if there's a history of aggressive behavior, because that could put the dental staff at risk. And so for my experimental group, for my participant 2, there will be 40 participants aging from 6 to 18. And the first group, they will receive the orthodontic care with the behavioral strategies, and this will last for 8 months, with them visiting every 2 weeks. And my control group will consist of 40 aging from 6 to 18. And this group, they will receive the standard orthodontic care without the behavioral strategies, and this will last for 8 months. With them visiting every 2 weeks. And so, for my data collection, I will be measuring their behavior and the use of sedation that will be gathered at different stages of the treatment, and tests that I'll be using the chi-square test, which is basically used to compare how often their sedation is needed in each group, and I'll be using the NOVA test, where that will track the changes in their behavior over time. My expected outcomes is that there will be a lower sedation rate in the experimental group. There will be an increase of treatment completion, and the parent would be more satisfied in the care of their child. That distinguishes their child during the treatment. And for future studies, future studies should look at how sensory-friendly orthodontic environments help patients with Down syndrome over time, not during one treatment. Research should explore how realistic and affordable it is to use sensory-friendly tools and behavioral strategies in rural dental offices. And future studies should compare patients with Down syndrome to those with other developmental conditions like autism, because this will help see which strategy will work well for most people and which wants to be adjusted for different needs. I would like to thank God, my family, friends, for everything we did this semester, and my professors. Here are my references. Any questions?
Hi. So when you say orthodontic care, you're specifically talking about like braces, correct? Or you're talking about like general,
Yeah.
When you mean and follow on that for sedation, do you mean like anesthesia, like local, or like mask, gas, IV? Which form of sedation are you discussing?
I guess mask.
Okay, so nitrous oxide.
Yeah.
You know what, I'm actually gonna address that as a clinician, from a clinician's point of view. Often when you have patients who have any kind of mental conditions like this, they have to be, they're medicated orally. They're given pills that morning. Often again, right before you go, before they leave the house to come there, they have to be sedated again. So it's not just anesthesia, it's to calm the anxiety before it, to even let you touch them.
How are you measuring anxiety, and then how are you measuring behavior?
Measuring their anxiety by using the modified childhood visual anxiety scale.
Can you tell me how that works?
I just know that this is a scale that measures how the anxiety level would be. I didn't like into.
But I mean, is the child doing that, or is the parent doing it, or are you doing it? I'm just confused.
I am doing that.
Okay. And then how are you measuring behavioral behavior and cooperation?
By using the NOVA test.
That's how you're analyzing the data. But where's the data
Statistics.
coming from?
I think I just did that.
So, the core of your study is your approach, which is your MCPAS, that modified child. So that should have been presented.
Yeah.
Because without that, how are we gonna know what you're doing?
Yeah.
That's the basis of your study. That's number one. So when you use that, if you're going to use that, then there's so many underlying questions on that. First off, is that designed for normal children, or is that designed for actually children that already have Down syndrome? Because if it isn't, then how are you going to modify that so that it fits to your patients, right? Like, again, that is the need of all of these that should have been presented, right? Because how are we going to know? Like, what are you going to do? We don't know. Right, so there's nothing now as basis of what we want to ask or how we're going to evaluate whether that would be good as an approach for you to do, right? But there's so many underlying questions on that. One is that whether it's designed already for Downs or not, then how are you going to modify it? The second is it's designed for children. Your target patients is 6 to 18. Is an 18 Down syndrome still fitting to this type of behavior? And like all of the categories that would have been in this MCDAS is the one that we should be looking at right now, right? Because like right now, there's really nothing. Like, what is the basis of all of what you are presenting if we don't have that? And how are you going to modify that? I think that's very, very critical to your presentation.
Tell me why every 2 weeks? 'Cause we barely get people to go to the dentist once a year.
Well, like for all our issues, I saw that with that, so I'm actually incorporating into my
So what is happening every 2 weeks? Is they getting cleanings every time? What's happening there?
I didn't do much research in depth with that, because I just saw that it said 2 to 6 months and then every 2 to 6 months, like,
Can you explain to me the difference between the first name and the second name? What were you doing? What were you looking at the two different times? Right, is one just their anxiety level and one is their behavior?
sensory friendly and behavioral strategy.
So can you give me examples of exactly what they would be,
Like,
what are you doing differently? So they go there.
Friendly, caring.
So is it just that one time that first time that they go there that those things are happening, or are they being prepped beforehand? You know what I'm saying? Like I don't understand. So this child comes in with their parent who has Down syndrome, and in that case, you're doing the dim lighting or the noise cancellation. Is there any like getting the child used to it before they come? I would think that would be very beneficial. So they would need. At one point, I heard you say that they would be allowed to touch things. Isn't there safety concerns over that? I mean, dental instruments are often very sharp, they're machinery.
Just so that they can get used to it, because some of them they get nervous. So just
All
like
kids get nervous when they go to the dentist, right? That's, you know.
Thank you. All right, we got some movement in and out of the room. I'll give you guys 1 minute and then we'll get set for our next presentation. All right, next I'm going to introduce to you Miss Jessica Weatherpole. She is majoring in biology with a concentration in medical sciences. She is from Lakeland, Florida, and has been at SEU for 4 years. While at SEU, she has served as a TA for genetics, Gen Chem, Intro to Science, Old Testament, New Testament, medical terminology.
Everything.
Pretty much everything, as well as being the president for SEMDA. After graduating, she plans to apply to PA school and work as a medical assistant. She has a heart for missions, and when she's not color coordinating her notebook, she's probably fundraising for her next mission trip to Africa.
Well, thank you, Dr. Hudson. As she said, my name is Jessica, and today we are going to be evaluating the relationship of living conditions on remission rates and decreasing secondary infection rates for pediatric acute lymphoblastic leukemia treatment in Uganda, a nonprofit health impact study. So this is a little bit of an overview about where we're going to be going today. We're going to have our background. We're going to give you guys some background information so you understand our specific aims 1 and 2. Then we'll have our expected outcomes, our future studies, and then we'll open up the floor for questions. So first, to start with our background, this study was very important to me, specifically on a personal level, because I've been to Uganda twice and I loved it. And on a more scientific reasoning, acute lymphoblastic leukemia, otherwise known from here on out as ALL, is the most commonly diagnosed childhood cancer globally. But specifically in Uganda, it has high infection rates with low survival rates. And also, no housing data for Uganda exists with cancer. However, it has been done in America and in other European countries. So just to give a little bit more of a background, Uganda is on the eastern side of Africa, on the equator, and they have a 19.9% survival rate, which means out of every 5 children who are diagnosed, only 1 is going to survive. This contrasts with America, which has an 80% survival rate. So we can see there's a big difference and a big importance to this study to be able to understand what that difference is. When we look at these studies, one of the things we're going to ask is there access to healthcare in this region since we have that big of a scope? And Uganda does have a lot of access to healthcare, specifically in pediatric oncology. So they have continual access to chemotherapies, as well as radiotherapy and trained oncologists. The one region that they're lacking in is in a trained, specialized surgeon for pediatric oncology. But they have one who's untrained, and they also have one who is trained for adult pediatric surgeries. So they have it, it's just not specifically for pediatricians. So for pediatric health in Uganda, malnutrition is one of the most common issues in Uganda. And malnutrition, I was looking more into it just to kind of see what it looks like. And malnutrition actually leads to a lot of anemia, a lowered immune system, and a high prevalence of infection, which is very important, as we'll see later on. But as we need to see this, we need to understand what leukemia is to understand the importance of how everything correlates. So leukemia is a rapidly dividing cancer in blood and bone marrow. It specifically affects lymphoblasts, and it disrupts normal blood cell production, which leads to anemia, infections, and bleeding, which we already saw are already an issue in Uganda. So specifically for this study, these are all the different types of leukemia that we can have. We're going to be specifically looking at lymphoblastic leukemia. So when we look at a blood smear for a pediatric leukemia patient, a healthy patient is going to be more on like the left side. We're going to see all those healthy platelets, healthy blood. We're going to love it. And then when we're looking at a blood smear for a leukemia patient, we're going to look more at a cancerous lymphocyte. We're going to see a lot of those, and we're going to be able to tell pretty right off that there's something wrong with the blood. So specifically for this study, we're going to be looking into remission and secondary infection. So we're going to just give a little bit of a background for that, just to kind of give you guys something to go off of. So for secondary infection, I like to think of your body as a castle. And your immune system is fighting against acute lymphoblastic leukemia, which is this huge army that's trying to invade your body. And so as leukemia is invading your body, you're putting up your forts and you're saying, we are going to fight against this with everything. Now, secondary infection, it's not going to be these big infections. It's going to be someone around you sneezed and you caught a cold. And it's going to act like a spy. It's going to come in behind you when you're not really ready for it, not looking for it. And it's going to take down your defenses really easily because you're not defending yourself from it. You're defending yourself from the leukemia. And so that's why secondary infections are so important when we look at cancer. Remission rates are a key goal of treatment, not just in ALL, but in all cancer. You really want to get to remission. But specifically for ALL is when the signs and symptoms of cancer are gone, which can be seen when there's no more cancer cells in the blood or the bone marrow. And it can be partial or complete, but just because you're in remission, it does not mean you're fully cured. You can go back into relapse. So on the other side of this, what is the impact of housing on cancer, on different things like that? In the US, many studies have been shown that housing insecurity worsens treatment outcomes. This is not just in cancer. This is across the board of healthcare. Mental health, different pediatric studies, all of these have shown that insecure housing has an impact. Also in the US, housing insecurity decreased attendance of doctor visits by 2 times. A study in Malawi showed that inconsistent housing was linked to ALL malnutrition. Just to stop here for a second, we've already seen that Uganda has an issue with malnutrition, and ALL causes different types of malnutrition and anemia. So this was really important to me to understand how this impact actually has. And no similar data has happened in Uganda yet, which is why I'm using the US and Malawi for these studies. So now that we've done the background, on to aim 1. My first specific aim is to investigate how different living environments influence secondary infection rates in pediatric ALL patients by analyzing immune function, infection susceptibility, and microbial exposure during treatment. And my hypothesis for aim 1 is that when housing is unstable, there will be an increase in secondary infection rates. So my inclusion for this study will be those who are less than 18 years old, because it's going to be a pediatric study. Those who are all on the same treatment regimen, because I wanted to take out some of those variables, and a complete informed consent both by the patient and by the parents. And my exclusion is going to be patients with pre-existing infections and those who do not consent to any follow-up forms. So for my research groups, I'm going to have 3 research groups. I'll have a control, which will be those who are living at home. They will drive themselves to and from their appointments, and they will be providing all of their own meals. I will also have a nonprofit experimental group, which is going to be living at a nonprofit facility. They will still have to provide their own transportation, but meals will be provided in a family style, so they'll all be eating dinner together, things like that. And then they will also have a hospital group, which will be living at the hospital. They will have their transportation to and from provided, and all of their meals will also be provided in their own hospital rooms. So our background methodology, our informed consent is going to have our demographics, our medical history, and a baseline infection monitoring through a standard blood workup. And then we're also going to do a nutritional evaluation, which will have a 24-hour dietary recall, a food frequency questionnaire, and a measure of their height, weight, and their upper arm circumference just to test for malnutrition. And then from those 2, we're going to classify them into the 3 groups and spread them evenly. And then patients for our specific aim 1, patients will report weekly for a CBC and also a follow-up. We'll check in with them, see how everything's doing. If either in our check-in or on the CBC, we find something that's a little interesting, we're going to go ahead and send them to additional screening, which will be blood cultures, stool samples, and a viral PCR testing to make sure that they don't have a secondary infection. Our data collection from those We'll be using a SPSS software, which will be a combination of chi-square tests and logistic regression to compare infection rates through each group. We'll also have a correlation analysis between immune markers and infection risks. And we'll have a final statistical analysis of a multivariate analysis that's adjusting for factors like age, treatment adherence, nutritional status, things like that. So for my specific aim 2, we will be evaluating the relationship between living conditions and treatment outcomes in pediatric ALL patients by assessing remission rates in the context of immune response, nutritional status, and treatment adherence. And my hypothesis for this is that if housing is unstable, there will be a decrease in remission and an increase in the length of time to complete treatment. We will have the same inclusion and exclusion rates as before, as well as the same 3 groups. Our background methodology will also be the same as our specific aim 1, but for specific aim 2, while we're using the same prospective cohort, this will be 12 months following their post-treatment initiation, so it won't be during the treatment. And we're going to be doing a serial CBC, which also is going to be looking for the albumin and the vitamin D, because albumin is a way to test for early remission. And then we're also going to be testing their treatment adherence. How many missed visits did they have? Because as we saw in the US, those with unstable housing were more likely to miss treatments, and we want to see if that also carries over to Uganda. For this data collection, we're going to be using a Kaplan-Meier survival curve, which is going to compare the remission rates between all of the groups, and also a cost proportional hazard model, which is going to adjust for potential confounders. So my expected outcomes, I'm expecting that those with the non-profit housing are going to have a lower secondary infection and a higher rate of remission. And I'm hoping that this can help us work with the Ugandans and the Ugandan government to bring more nonprofits into Uganda to hopefully increase patient outcomes, especially in pediatric ALL. And for future studies, I would love to see a similar study with a little bit more specific. I feel like this was really broad, and I would have loved to have specified it a little bit more. I also would like to see the nutritional addition of microgreens, because I think microgreens are a really easy way to get nutrition in, and I think malnutrition being so big, I would love to see some examples of how we can fix that. And also, as I was doing my studies, I was wondering if there's a correlation between sickle cell anemia and ALL, because a lot of that was coming up, but no one has ever seen the correlation between the two. I would like to acknowledge my professors, Dr. Hudson and Dr. Abraham, Dr. Ibram, who is a doctor in Uganda, who I actually called to see what the current treatments are, my family, my friends, and God. And these are my references. Any questions?
Yes, so first of all, I just wanted to say I love all of your figures, and I think that your analogy with the castle was amazing. I do want to ask you, and just like see what you think about this. Are you going to be using patients that are in different stages of their cancer? And how do you think that your specific aims will impact the patient and their secondary infection rates based on what type of cancer they have, like stage 1 or stage 2?
That's a good question. I do think for this study, I'll be using all ranges, which is why I put in my hopefully my future studies, I would like to do a more specific study of all of them being diagnosed at the same time and having the same like types of treatment, type of cancer, all of that, and just being able to take out a lot more of those variables. I think that being able to catch a secondary infection quickly, especially in those weekly treatments, I think that'll help a lot. Just in how well they're able to go into remission and being able to make it to remission. So hopefully we're going to take that 19.9% and make it a little better. That's a great question.
Can you help me understand more your third group are those living at the hospital?
So they were specifically at the hospital for their treatments, and they were getting we were providing transportation for them, and their housing was provided specifically for them, not that they were but also just
when they're not at the hospital, where are they? They're homeless, living on the street.
Probably not on the street. That is a great question. That's something that I had thought about, but had not yet been able to problem solve that.
The way I understood it is they were staying at the hospital, so then it confused how were they not getting well treatment throughout if there's always at the hospital constantly monitored.
That was the hope, is that they'll be able to stay on hospital, be constantly monitored. I'm not quite sure in Uganda if that's the current treatment plan, and if, like, what they do in Uganda for that specific, that was a question that I had that we didn't have time to get answered. So that's something that I'm gonna look into and get back to you on.
And are the nonprofits that are mentioned in the study, what is already being done in Uganda?
So I actually spent 2 months in Uganda this past summer, and I got to visit a nonprofit who was doing this. And they kind of took a little bit off of the Ronald McDonald houses here, but took it to Uganda. And it's a Ugandan who now has 5 different homes in Kampala. And he has one for palliative care and a few others just for broad cancers. They're doing an incredible job, and they've actually had a really high remission rate of all of the kids who have come into there. They allow parents to stay with them. I could go on and on about this house because I literally loved it. It was probably my favorite part of being in Uganda. But it really influenced why I did this study. Was I would have loved to see him have a little bit more aid from a lot of people, because you're seeing the treatment outcomes and what he's doing, and he's seeing those statistics, but he doesn't have the funding and he doesn't have the help. And I would love to see us work with them a little more. Yes, one more, and then.
Is this a study that can actually be done in Uganda?
Yes, this study can be done in Uganda, which is why I worked so heavily with Dr. Ebram and making sure that this was all within the scope of what they're already using in Uganda, which is why there were some better testing that I probably could have run, and some different things that, looking into my studies and doing more research, I was like, oh, I really would have loved to have done this test. But I always went back to Dr. Ebram and made sure that that's something that they do in Uganda to try to make this as feasible of a study as possible. Yes.
So you mentioned you're going to do your chi-square analysis for your data analysis later on.
Yes.
Which model are you going to use to refer to as for your expected values?
So I was looking into chi-squares, and I couldn't tell the difference between the models. All I got as I was searching them was the actual formula for a chi-square model. So that's something that I was going to do more research into that I have not yet done, because I was trying to figure that out.
It's a very critical. I think it's a very good approach, because again, when you do something like this and then you have a model to refer to, the critical part is which model are you actually going to use to qualify, right? Like, okay, yeah, this is really already observed based on my chi-square, so that's really critical.
I was trying to look at that.
All right, thank you so much.
We're going to go back to S119 for 2 last research presentations. It'll be done 20 minutes.
I love the castle analogy too.
You did great, Jeff.
That's great. No, you did great. Wait, so what's the counter? Who's the counter spy to the spy that is the secondary infection?
I don't know. I would have loved to find that out. I'm gonna have to do that.
Like who's the secret agent on the good side who's trying to find that one? Yeah. Great job though.
Okay, to do this,